The subject that I'm going to talk about is a little bit boring for some if you don't manage patients with cancer. About 21 years ago, I joined MD Anderson. I didn't know anything about cancer patients because cancer patients were excluded from ICU admission. Not only that, I couldn't find any book about it. There were very rare textbooks about immunodepressed patients that basically were dealing mostly about HIV patients. In the last 20 years, I have basically focused my research and my activities in educating large groups of societies, etc., especially in Latin America, very hard in the United States. Everyone knows everything there. So I think that we have gained a tremendous amount of knowledge in these past 20 years. We published a textbook, etc., and we have done some, not necessarily great science, because it's very difficult to do research in this population. Just to give you a couple of examples, and this is kind of introductory to the subject. We always talk about precision medicine, as Dr. Levy was talking about, but we are very imprecise because we think that we know what we're talking about, but we cannot even define the diseases we are managing. If you cannot define your disease, you really don't know the disease that you are managing. So I don't have any conflict of interest, which is very sad. The main objectives are delineated here. First, I'm going to talk a little bit about MD Anderson and the type of patients that we manage. So you basically understand where I'm coming from, because these are patients that are not seen everywhere. Then I'm going to talk a little bit about immunotherapy today, as you saw from the lecture of Dr. Levy as well, that immunotherapy is becoming one of the main tools to manage patients in critically ill patient populations. And not only that, I think that if we don't learn immunology in the future, we're just not going to be able to manage our patients. The third thing is talk about what are the adverse events associated with these immunotherapies, and a little bit about management and our experience. So why is important to talk about the population I manage is because our hospital is the largest center in cancer in the world. We manage tremendous amount of patients. We see in the outpatient clinics about 2 million patients a year. And in the ICU, we used to see about 3,700 patients a year. In the hospital, we see about 26,000 patients admitted every year. And that has given us large volumes to notice trends and changes very easily. Our hospital spends more than $1 billion in research every year. Of course, mostly dedicated to cancer. Being an intensivist is mostly a supportive type of physician, and we don't cure cancer, so we are not a priority in the institution. And other thing that happens with cancer patients is that they are usually excluded from almost every single randomized trial, because those patients have very high mortalities and almost always have exclusion criteria when you look at that. So look at, for example, this is a little bit difficult to manage, but the budget of the hospital is $6.2 billion a year. I usually put this slide because this is what it was respiratory failure 20 years ago. And this is from Europe, but it was, when you look at the rest of the data in Latin America from the Brazilian studies and other studies that were done later on by Jean-Louis Vincent, very, very similar. So you have 85% of the patients that were admitted and were intubated, and 15% of the patients managed with non-invasive ventilation, which has changed significantly over the years. If you look at epidemiological data from Hannah Wunsch in the studies in the United States, you see a trend going up with the use of non-invasive ventilation, and also in our hospital. So the first study that I did when I came to MD Anderson was to look at patients that were receiving high frequency ventilation, and almost everyone was dying. Eventually, we got rid of the high frequency ventilators because it was not useful. Then we started to study this particular population, phase 1 trial population, which means patients that were already so advanced that only therapies that were experimental were provided to them. And these patients basically were kind of futile. And eventually we stopped admitting them to the ICU because out of 3, 1 will die in the ICU, 1 will die before being discharged from the hospital, and 1 will die within the first 90 days. The only people that were surviving were the patients that were post-surgery, or that were considered surgical patients. Then we started to look at the leukemia patients because the leukemia doctors thought that all their patients do very well. And then we look at 167 patients consecutively, and we found that the mortality in the ICU was 77%. These are all intubated patients, mechanically ventilated. And then the mortality before discharge or at discharge of the hospital was 83%. Very sick population. Then we did this study that is a study looking at non-invasive ventilation. And we included about 1,600 patients. And you can see here, half of them were intubated and half of them have been initiated with non-invasive ventilation. At this time, we did not include high flow because we were looking at ventilation interventions, no oxygenation therapies. And as you can see here, the length of stay, the mortality is very high in the patients that failed non-invasive ventilation, even higher than the patients that actually were intubated from the very beginning. And we intubated these patients from the very beginning because they are the ones that arrive in very acute distress that would not tolerate non-invasive ventilation or had a contraindication for non-invasive ventilation. And the hospital mortality, you can see here, less than 50% in the non-invasive, and 80% on the patients that failed non-invasive ventilation. So there were some indicators that were associated with higher mortality with, like, severity of illness and things like that. And you can see here the survival curves that basically within the first year, almost everyone died. And those that survived the first year survive a longer period of time. And most recently, we haven't published this data. It's a data in which we actually randomize patients with a PF ratio of less than 300 or an SF ratio less than 315 to high flow or non-invasive ventilation. And a lot of exclusion criteria. What we notice is that 26% of the patients that we have tried to put in non-invasive ventilation actually did not tolerate the non-invasive ventilation. The mask was too tight, the pressure was too high, etc. That didn't happen with the other patients. But pay attention to this. 1 out of 5 got intubated. No difference in that. The mortality was not very different, but the mortality was less than 50%, even in patients that eventually were intubated. So I will skip that, those conclusions. We can talk about that at the end. Immunotherapy and respiratory failure. So as you know, in 2018, a couple of investigators received the Nobel Prize because of the work that they have done in using the immune system to attack, the aggressor cancer in the body. And of course, they have started just recently to use these medications. I think the first time they used one of these immunocheck inhibitors was in 2005, and in a patient from Sloan Kettering in New York. Okay, so 2005 calculates about 18 years. And in a matter of a few years, they got the Nobel Prize because of the amazing results that they had. There are many therapies these days: monoclonal antibodies, CAR T cells, cytokines, anti-PDs, etc. And of course, the old therapies, steroids, azathioprine, other type of immunosuppressors. So you can see here the different types of groups, like the checkpoint inhibitors, monoclonal antibodies, or immune effector cells, and all the types of immune effector cells that they are, like car, trucks, wagons. I know they have so many different terminologies that you need to have a physicist degree to understand what they're talking about. So this is a graph that I'm showing you just for you to see the timeline of the introduction of these therapies and what is happening right now. So there has been an explosion since 2015, all these cancers that now are candidates to receive immunotherapy. Before, there was only melanoma. So the first patient that was treated in Sloan Kettering, that they give her ipilimumab, she was basically a phase 1 patient. She was considered a dead patient. They gave her the drug, and a month later, when they did a follow-up of the X-rays, etc., the radiologist called the oncologist and said, "What did you give this patient? She's cured." She basically had completely wiped out all the metastases she had all over the body, and that is the reason for these individuals to get their Nobel Prize. As you can see here, some of them are more associated with pneumonitis, like kinase inhibitors or monoclonal antibodies. The CAR T cells are more associated with neurotoxicity, etc. And then you have some others that are associated with pulmonary embolism, like the CD kinase inhibitors. So when you talk about immunocheck inhibitors, what happens is that these drugs actually target the PD-L1s or PD-1, and then inhibits the connection between the T cells and whatever other cell is attached to it. And when you disinhibit that, when you just block that contact, what happens is that you activate the T cell, and then the T cell is active and destroys the tumors, the tumoral cells. In this particular case, we're talking about cancer. So you have the CTLA4. Ipilimumab is a CTLA4 immunocheck inhibitor. And then when you see what happened with these drugs, well, they are fantastic, but they have side effects. Among the adverse effects are all over. So you can have endocrinologic effects, neurologic effects, even dermatological changes. Look at all the trends and when they appear. For example, pulmonary, the toxicity appears within the first 12 weeks. And if you look at the incidence of these adverse events, look at the rates. If you combine, for example, a PD-1 with the CTLA4, you have 95% chance of getting a grade 1, grade 2 toxicity, and more than 55% to get a grade 3 or 4 toxicity. So this is serious. And then this is a systematic review and meta-analysis done of 125 trials in which 66% of the 12,000 patients develop a grade 1 or 2 adverse event. And out of them, 14% develop a grade 3 or higher. And among the patients that die, 28% die from pneumonitis. So you can see in this picture, all the different types of ways that these high-risk agents can affect the patients and lead to respiratory insufficiency or respiratory failure. So pneumonitis is one of them, muscular failure, you can have Guillain-Barré, you can have myasthenia gravis, and of course, all the symptoms, dyspnea, bronchospasm, cough, shortness of breath, all this symptomatology that we already know about the patients that have respiratory failure, and then the treatments go from anticoagulants to intubate the patient and ventilate the patient, including steroids, oxygen, bronchodilators, etc. This is a table on the grading from the National Cancer Institute. So you have from 1, a patient that is asymptomatic, but they have signs, and 5, the patient is dead. Now, the most important are the 3, severe symptoms or limiting self-care, patients that need hospitalization and need oxygen. When you look at the radiographic patterns, it's all over the place. If you show me an X-ray or a CT, I can tell you a salad bar for me. You have patients with pulmonary edema, patients with pneumonitis, with pulmonary fibrosis, with tumor, and then metastatic or no metastatic. Then you have pleural effusions. Like, how can you make any sense out of all these different patterns? Diffuse alveolar injury, hypersensitivity, pneumonitis, et cetera, again, the precision of the terminology and how can you actually talk about a particular problem like pneumonitis, for example, in a patient that has a pleural effusion, metastases, and other problems like pulmonary fibrosis from radiotherapy previously. So very, very, very difficult. So I don't pretend to be an expert in the subject. I just have a lot of experience managing these patients. You have here an example of a patient with non-small cell carcinoma developing pneumonitis with nivolumab. You have other cases, myasthenia gravis is a problem. We have how do you call it, an outbreak of patients with myasthenia gravis a few years ago, which I will mention at the end. You can see here, pembrolizumab was one of them, the most frequently found associated with it. Guillain-Barré, multiple cases reported in the literature. I have seen a lot of patients with Guillain-Barré associated with this. Recently, I haven't seen any in the last few months. You can see ipilimumab, mainly the culprit. You have pembrolizumab, who are associated with a patient with bulbar myopathy. They did amazing description. They did all the studies possible that you know, but the patient died. You know, it's like the pathologist. Remember the joke? In any case, again, pneumonitis with pembro, immunotherapy-induced pneumonitis, anti-PD-1 immunotherapy, associated pneumonitis, etc. So what is the management? The management is relatively simple. First of all, you need to be aware that this can happen. And then once you have the first signs of the patient developing some type of respiratory distress or all the problems, no? If the toxicity is neurological, then you also have to pay attention to the neurological signs. But basically, the first thing is to consider when to stop the medication. The second is when do you need to do antibiotics? And usually you start with antibiotics because those infiltrates could be an infection. Sometimes the patient have fever. And then steroids if the patient doesn't improve. Then if the patient continues to get worse, you admit the patient to the hospital, put the patient on oxygen, and continue with more immunosuppressive therapies like infliximab. This is the latest document that exists in the literature, was published in October 2022 by the European Society of Medical Oncology, and is very well described with all the doses of the medications that you need to give, the steroids. You start with oral steroids, and then you change to methylprednisolone IV, etc. And then I cannot see from here, but basically what you do, you escalate. And of course, then you go for the cytokines. You go with anti-L6 or anti-L1, and then you add other like MFM, additional immunosuppressive therapies, etc. And if the patient responds, then you leave the patient for 2 months and 6 to 8 weeks of steroid therapy, etc. So what happened in MD Anderson? So you understand, in case that your hospital start to use more and more immunotherapy, because it's important. So a few years ago, about 2016, 2017, we noticed that the number of patients that were requiring intubation was rising very rapidly. And there were a couple of months that we have to ask ventilators borrow from another hospital across the street because we didn't have enough ventilators to manage those patients in that period of time. And then when we look back in the what had happened in the hospital is we have noticed that there had been an increase. Remember what I showed you, the graph with 2015, with all these other cancers enter the picture that you start to use immunotherapy. So that's what happened, basically. The patients started to receive immunotherapies, and because we still had not calibrated our response to the symptomatology of the patients, what happened is that these patients started to develop Guillain-Barré, myasthenia gravis, and they were coming to the ICU with all these problems, and many of them intubated or pneumonitis, etc. And that's what happened. And you can see the mortality here is 54% and 55% in both groups. It's not because these patients now are improving outcomes. Like you can see multiple publications in the literature, especially coming from Europe. Oh, their respiratory failure has improved, but the issue is you need to look at the data very careful because you always miss the denominator. So this is a very selected population, isn't it? One of the things that we need to look at the future, and it's something that is not approved in the United States, is the use of helmets for non-invasive ventilation. And unfortunately, there is only one study that was published. This is from a systematic review meta-analysis published in 2020, and showing lower mortality, significantly lower mortality, and all-cause mortality here. Sorry, this is back. And this was intubation rates. Okay. So I cannot tell you much more about helmets because it's the only thing that I don't have much experience on, but I can tell you that it's something that we need to be looking after. because when you look back at the data that I presented to you in the first studies that we did, and the one that we haven't published, is that the patients that are in the floor are in respiratory failure and are being managed by, respiratory therapies in a combination with ICU teams that go and do outreach with high flow and non-invasive, a combination therapy. We use non-invasive ventilation only when the patients have some sign of respiratory difficulty, like a supraclavicular retractions or intercostal retractions. Otherwise, we continue with high flow. And we can even keep patients in the floor that sometimes are even 100%. It's a little bit misleading, because you come sit the patient in his room, and they are even eating and look comfortable. The patient feels okay, and is on 100% high flow. So this patient a few years ago will be intubated, but those patients are usually doing very well. So what is happening is that the population we intubate these days, that is getting 75% mortality in our publications, is the worst of the worst of the worst. Those patients that do not tolerate high flow, that didn't tolerate high flow plus non-invasive ventilation, and they fail non-invasive ventilation. So those are the sickest patients. So I have a lot of time to keep going. So I don't know if you have any questions for me, or you want to decide to do a session. So I will stop here. Basically, I think that the most important thing is, if you are doing immunotherapy in your hospital, is learn all the signs. And second, if you want to manage these patients, refresh your immunology. Thank you.